Imagine going to the doctor because, well, every time you cough or laugh or lift something heavy, you leak urine.
Right. It's totally dictating your life.
Exactly. It dictates your wardrobe,
Yeah.
your social life, your mental health. So the specialist runs the most advanced gold standard diagnostic test available. You wait for the results, and the machine prints out a report saying, basically, there is absolutely nothing wrong with you.
Which is incredibly frustrating.
Right. But for a massive percentage of women with hypermobile Ehlers-Danlos syndrome, or EDS,
Right.
that isn't some hypothetical medical mystery. That is a Tuesday.
It really is a profound clinical paradox.
Yeah.
Because we're looking at a patient population where the fundamental blueprints, the ones we rely on to understand the human body, they just don't match the physical reality of the person sitting in the exam room.
Wow.
Yeah, the tools are essentially, they're gaslighting the patient.
Well, welcome to today's deep dive. Our mission today is to solve this exact mystery. We're exploring a highly specific but incredibly illuminating intersection of medicine.
Right, specifically how women with joint hypermobility, or EDS, navigate treatments for stress urinary incontinence, or SUI.
Exactly. And to figure this out, we're pulling from a really fascinating stack of sources. We've got a major cohort study by Davidson and colleagues, some highly specialized physical therapy literature, and clinical proceedings from urogynecology conferences.
That's a great mix of data.
It is.
Yeah.
So whether you have a hypermobility disorder yourself, or you know someone who does, or you just love unpacking a puzzle where the medical playbook has to be completely rewritten. So what does this all mean? Let's find out.
I think the best place to start is with the actual mechanics of the pelvic floor, right? Because that's where the physical failure is actually happening.
Okay, lay it out for us.
To grasp why stress urinary incontinence is such a massive issue for hypermobile patients, we need to look at the anatomy of a leak. So SUI occurs when physical activity puts downward pressure on your bladder.
So if the urethra, the tube that carries urine out of the bladder, if that drops down under that pressure, why does that cause a leak? Like, what is supposed to be holding it in place?
Well, in a typical pelvis, the urethra rests on this really robust supportive hammock. It's made of muscles, ligaments, and fascia.
Right, so it's a structural thing.
Exactly. When you cough, the pressure in your abdomen spikes drastically, but that hammock provides a firm, rigid backstop. The urethra basically gets sandwiched between the downward pressure and that firm hammock, compressing the tube shut. No urine escapes.
But the sources indicate that for patients with SUI, this whole shock absorption system just fails. I think it's driven by a state called urethral hypermobility. I'm assuming that means the hammock is basically given out.
Essentially, yes. The urethra loses its anatomical anchor, so when that downward abdominal pressure hits, there's no rigid backstop anymore.
Oh, I see.
Yeah, instead of compressing shut, the urethra just gets pushed downward into the vaginal space. Because it drops, rather than flattening out against something solid, the seal isn't tight, and the fluid escapes.
Okay, let's unpack this with a visual, because that really helps me. It's like trying to build a reliable suspension bridge where the road is supposed to be held firm by these massive steel cables.
Right.
And when a heavy truck drives over it, the cables hold the tension, and the bridge stays flat. But with urethral hypermobility, it's like someone replaced the main cables with old bungee cords. The structure is there, but the tension is all wrong. The truck drives over, and the whole bridge just sags deeply under the weight.
That captures the mechanical failure perfectly. Now, let's apply that bungee cord reality to a patient with hypermobile Ehlers-Danlos syndrome. EDS is a genetic disorder affecting collagen, right?
And collagen is basically everywhere.
Everywhere. It's the most abundant protein in the body. It forms the scaffolding of your skin, your tendons, and crucially, your pelvic organs. But in EDS, the genetic instructions for building that collagen are flawed.
Meaning the materials are bad from the start?
Exactly.
Yeah.
The resulting biological material is inherently weak, overly elastic, and just incredibly fragile.
The clinical impact of that genetic flaw is honestly staggering when you read the data. According to the international survey data in our sources, an astonishing 60% of cisgender women with hypermobile EDS report experiencing stress urinary incontinence.
60%, which forces clinicians to walk a very, very dangerous tightrope. I mean, if a patient's internal support system is made of faulty biological material at a cellular level, how do you treat the leaking without just breaking the tissues further?
Right. Which brings us to the non-surgical solutions, the first line of defense. The literature is super clear that surgery is considered an absolute last resort here.
Oh, absolutely.
So the first step is usually pelvic floor physical therapy or PFPT. But the literature throws up a huge warning sign here. Handing an EDS patient a standard pamphlet on Kegel exercises can actually trigger severe chronic pain and make the dysfunction worse.
Yeah, the huge problem.
But why? I mean, if the muscles are weak, shouldn't strengthening them be the obvious answer?
It seems so counterintuitive until you look at what the pelvic floor is actually doing in an EDS body. Because the ligaments, your bungee cords, are so lax, the pelvic floor muscles are forced to work overtime.
Ah, to compensate for the ligaments.
Precisely. They are constantly in a state of spasm and hypertension, gripping tightly just to keep the pelvic organs from prolapsing.
Wait, really? So they aren't weak from underuse. They're exhausted and locked up from doing the job the ligaments are supposed to be doing.
Precisely the opposite of a typical SUI patient. So if you tell an EDS patient to perform hundreds of intense Kegel contractions, which involve squeezing those muscles even tighter upward, you're basically throwing gasoline on a fire. You trigger severe pelvic spasms.
Jeez. So what on earth does specialized physical therapy look like if you can't do traditional strengthening?
Well, the physical therapy literature heavily emphasizes a technique called biofeedback.
How does that work?
Instead of just guessing how to squeeze, the patient uses sensors placed on or inside the pelvic region that connect to a monitor, so they can visually see their muscle activity on a screen in real time.
Oh, wow. So it's highly individualized.
Very. It allows them to focus on relaxing those overworked muscles and coordinating their contraction properly. It's about mapping their nervous system rather than just brute forcing the tissue.
Rebuilding that brain-body connection. The sources also mention something called hypopressive exercises. What is the mechanism behind those?
Hypopressives are fascinating. They utilize specific breathing and posture techniques to create a vacuum effect in the abdomen.
A vacuum effect.
Yeah. Instead of bearing down and putting pressure on the pelvic floor, the patient uses their diaphragm to essentially pull the abdominal contents upward. It drastically reduces the mechanical load on the weakened connective tissue.
Basically taking the heavy trucks off the suspension bridge entirely. Now, when physical therapy plateaus, the sources bring up mechanical devices, specifically pessaries.
Right, pessaries.
Which are these removable silicone inserts that go into the vagina to physically prop up the prolapsed organs and support the urethra.
And they're an incredibly effective, minimally invasive solution for the general population. But again, the underlying biology of EDS complicates things due to something called mucosal fragility.
Because the tissue lining the vaginal walls in these patients is incredibly delicate.
Very much so.
The analogy I kept thinking of was trying to wedge a firm rubber ring inside a tube made of wet tissue paper. The mechanical friction of walking around with a pessary all day can easily cause the tissue paper to erode or blister or bleed.
That's a very accurate visual, which means pessary use in EDS requires meticulous professional fitting and just constant monitoring. Clinicians often prescribe topical estrogen cream alongside it.
To help the tissue.
Exactly. The estrogen helps bulk up the vaginal mucosa, essentially thickening that tissue paper so it can better tolerate the friction of the silicone.
Okay, so conservative treatments require walking on eggshells. But before we talk about what happens when those fail, we have to address that diagnostic disconnect I mentioned at the very start of the deep dive.
Oh, the urodynamic anomaly. This is wild.
It really is. The clinical proceedings from MPRS, that's a major pelvic reconstructive surgery conference, they detailed a retrospective review of 27 patients with hypermobile EDS.
And it highlights a massive blind spot in standard medical testing.
Right, so these 27 patients were being evaluated for lower urinary tract symptoms. They were actively reporting subjective symptoms in their daily lives, urinary frequency, waking up multiple times a night to pee, and of course, stress urinary incontinence.
Right. They are literally telling your doctors, I'm leaking.
Exactly. So the standard protocol is to run formal urodynamic testing, or UDS, which is this invasive objective test.
Yeah, clinicians place small pressure-sensing catheters directly into the bladder and the rectum. They slowly fill the bladder with fluid and instruct the patient to cough or bear down.
While a computer measures the exact internal pressures and monitors for physical leakage.
Right. And the results for these 27 EDS patients? 0. The testing found absolutely no evidence of stress urinary incontinence, no detrusor overactivity, no incomplete emptying. The machine essentially called the patients liars.
Wait, if the patients are telling doctors they are leaking, but the objective machine says no SUI detected, what is happening? Is the test failing to capture the reality of EDS tissues, or is something else entirely causing the incontinence?
This raises an important question, right? The clinical consensus is that the test is completely failing to capture the dynamic reality of an EDS body. You have to consider the environment of urodynamic testing.
Which is very clinical.
Yeah, it's conducted in a sterile setting, usually with the patient seated in a specialized chair, largely stationary.
Ah, I see. But EDS is a disorder heavily impacted by gravity and time.
Exactly. Connective tissue failure in these patients often manifests after prolonged standing, walking, or at the end of a long day when the compensating muscles are just completely fatigued and those lax ligaments finally just give out.
Oh, wow.
The static momentary stress of a clinical test doesn't replicate the real-world mechanical exhaustion that actually causes the system to fail.
You can't test the safety of a suspension bridge by parking a single compact car on it in a windless laboratory for 10 minutes.
Yeah.
You have to see what happens during a rush hour hurricane.
That's a perfect way to put it.
It just proves that clinicians absolutely must listen to the patient's lived experience. The machines are calibrated for a biology these patients simply do not possess.
Which brings us to the most daunting phase of treatment. When conservative measures fail, when physical therapy plateaus and pessaries cause too much tissue erosion, patients and doctors eventually have to brave the operating room.
But wait, if I'm an EDS patient reading the data we're about to discuss, I'm running for the door. Operating on this tissue sounds like a surgical minefield. We're looking at a multi-center retrospective cohort study published by Davidson and colleagues.
Right, the Davidson study.
They compared 59 patients with hereditary disorders of connective tissue, or HDCT, against 118 control patients undergoing pelvic floor reconstructive surgery for prolapse, or SUI.
And the primary surgical intervention here is a mid-urethral sling. Basically, the surgeon places a small strip of synthetic mesh underneath the urethra.
Okay.
The goal is to permanently replace the faulty biological hammock with an artificial structural backstop.
Replacing the bungee cords with actual steel cables. But the tissue they're anchoring this mesh to is described in the study as incredibly friable. What does it actually look like in an operating room?
Well, friable tissue is tissue that readily tears, fragments, or bleeds when it's manipulated. If a surgeon attempts to grasp it with forceps, it might just shred. Yeah, and most concerningly, it holds sutures very poorly. When a surgeon places a stitch to anchor that mesh sling, they need the surrounding tissue to hold the thread tightly. In EDS, the tension of the thread can literally pull right through the muscle, like a wire cutting through cheese.
Unsurprisingly, this results in a massive spike in complications. The Davidson study found a 46% perioperative complication rate in the connective tissue group, compared to just 22% in the control group.
It's a huge jump.
And their hospital readmission rates were nearly 5 times higher, 14% versus 3%. Why would any surgeon agree to do this, and why would any patient risk it?
Well, we have to look closely at the nature of those complications. The study explicitly notes that the vast majority were Clavien-Dindo grade 1 and 2 complications.
Okay, for those of us who haven't been to medical school, break down the Clavien-Dindo scale for us.
Of course. It's a standard system for classifying surgical complications based on how aggressive the required treatment is. Grade I complications are, minor deviations from normal recovery that don't need drugs or surgery, things like bedside wound care.
Got it.
Grade 2 complications require pharmacological treatment, such as a course of antibiotics for a superficial infection or a UTI.
So we aren't talking about grade 3rd, which would mean rushing the patient back into the operating room to fix, like, a massive internal hemorrhage.
Thankfully, no. The complications they experienced were mostly things like diffuse bleeding or prolonged urinary retention, meaning the patient needed to go home with a catheter for a week or two, or dealing with wound hematomas.
Minor in the grand scheme of surgical disasters, perhaps, but still incredibly painful, distressing, and disruptive for a patient who's just trying to heal.
Oh, absolutely. The recovery period is undeniably harder, longer, and more fraught with setbacks.
But here's where it gets really interesting, because I was bracing myself for the ultimate bad news. I assumed that with a 46% complication rate in tissue that shreds under a needle, the synthetic slings must just rip out and fail entirely.
You'd think so.
But the study found that at the 6-week mark, there was absolutely no difference in the recurrence of SUI between the two groups. Both hovered right around an 11% failure rate.
What's fascinating here is that it completely reorients how we view success in this population. The mechanical intervention, the mesh sling, actually does work.
It creates the backstop.
Exactly. The surgery itself isn't necessarily the failure point. The vulnerability is entirely in the healing process.
Which means if a surgeon wants to get an EDS patient to that successful finish line, they have to fundamentally hack their own operating protocols to keep them safe. You just cannot treat them like a standard surgical case.
No, you can't. The surgical playbook has to be rewritten from the moment the patient enters the room.
Yeah.
We talked about how the tissue tears under tension, right? So surgeons have to utilize entirely tension-free closures. If they pull a stitch as tight as they normally would, the wound will undergo dehiscence.
Meaning the incision will just split wide open in the days following the surgery.
Exactly. And those sutures often need to be left in place for twice as long as normal protocol dictates, purely to give that faulty collagen extra time to form a scar that won't just give way.
It's like baking a cake, but you're using almond flour instead of wheat flour.
Oh, I like that.
Yeah, you can't just use the standard recipes, baking time and temperature, and
Mhm.
expect the cake not to collapse. You have to change the entire methodology. And post-operatively, the nursing protocols change drastically too, right?
Oh, completely. Even routine things like removing adhesive medical tape or frequent dressing changes can cause severe skin blistering and trauma for an EDS patient, so they require much longer periods of pelvic rest and physical immobilization.
Because their early healing stages are so perilous.
Yes. It takes a massive multidisciplinary team to manage this, and one of the most critical aspects, which honestly often gets overlooked, is anesthesiology.
The anesthesia notes in the sources were wild to me.
Mm.
Why is putting an EDS patient to sleep so much more complicated?
Well, there are two major reasons. First, their joint hypermobility means they are at a very high risk for joint dislocations while they are unconscious and being positioned on the operating table.
That makes sense.
So the team has to move them with extreme caution. Second, many EDS patients have documented resistance to local anesthetics like lidocaine.
Wait, that is terrifying.
Well,
The sources cited case reports of local anesthetic allergies and failures. If your anesthesiologist doesn't know that your connective tissue disorder actually alters how your body processes pain medication, you could wake up in agony.
it's a very real risk. If we connect this to the bigger picture, it proves why personalized medicine is an absolute non-negotiable necessity.
Oh.
Applying a rigid standard of care blindly to a patient with a systemic tissue disorder isn't just ineffective, it causes active harm. It creates complications that could have been prevented if the medical team had just adjusted their methodology to suit the biology they were working with.
It's incredibly validating data. For anyone listening who has had to advocate for themselves in a clinical setting, your body just operates on a different set of physical rules.
And when the medical team respects those rules, we see from the Davidson data that success is genuinely possible. A mid-urethral sling can provide life-changing relief, provided the team meticulously navigates the healing phase.
So let's pull all these clues together. We started by exploring how a systemic lack of collagen support turns the pelvic floor into a set of faulty bungee cords, causing urethral hypermobility and incontinence.
Right, and then we saw how conservative treatments require highly specific workarounds, from biofeedback to avoid muscle spasms, to using estrogen to prevent pessary friction erosion.
And we uncovered how static clinical tests completely miss the dynamic reality of an EDS body in motion. Finally, we navigated the surgical minefield. A 46% complication rate is definitely daunting, but the structural fixes can succeed if the surgical playbook is radically modified.
The overarching lesson here is that medical intervention cannot just be about the mechanics of a procedure.
No, knowing what is broken is only half the battle. Knowing the exact biological material you are trying to fix changes absolutely everything.
It changes the surgical approach, the risk profile, and the timeline for a successful recovery.
But before we wrap up today, I want to explore a final forward-looking thought drawn from the fringes of our sources. We spent this deep dive talking about mechanical fixes, synthetic mesh, silicone rings that don't play well with faulty collagen. But the literature briefly mentions emerging biological therapies.
Ah, like platelet-rich plasma.
Yes, PRP. The idea is to inject the healing factors from a patient's own blood directly into the damaged tissue to stimulate regeneration. So, could we eventually regenerate the pelvic floor connective tissue and make these surgical slings entirely obsolete for hypermobile patients?
It's a very hopeful thought, but we have to push back on the biology there a bit. EDS is a genetic disorder. The instructions for building collagen are fundamentally flawed.
Okay.
So if you use a patient's own blood plasma to stimulate tissue regeneration, aren't you just building more of that exact same faulty collagen?
Oh, wow. That completely changes the equation. If the DNA is the problem, you can't just copy and paste it. So what is PRP actually doing in these cases, if not regenerating perfect tissue?
Well, it is more likely that biological treatments like PRP are working by drastically reducing localized inflammation or perhaps stimulating the formation of robust, dense scar tissue.
Ah, scar tissue.
Yeah, that scar tissue acts as an internal support rather than actually rewriting the patient's genetic collagen structure.
That makes total sense. We aren't curing the genetic flaw. We're just finding smarter biological ways to reinforce the building. It completely reframes how we might treat systemic connective tissue failures in the future.
It really is a horizon that offers a lot of nuanced hope for a patient population that desperately needs better tools.
Definitely something for you to ponder until next time. Because
Yeah.
as we've learned today, when you're looking at the murky waters of connective tissue disorders, you can't just stare at the standard textbook and expect to see the truth. You have to understand exactly what the building is made of.